Everyone, and welcome back to the channel. Let me ask you something. Have you ever been in a situation, maybe facing surgery, dealing with a health condition, or just thinking about the future and wish you had a crystal ball? The little peek into what might happen? Of course, real crystal balls don't exist. But what if I told you that doctors do have tools powered by data from millions of patients that can help predict potential outcomes? Almost like specialized calculators for health. Sounds a bit like science fiction, right? But it's very real and is playing an increasingly important role in the healthcare today. We are talking about clinical prediction calculators or risk scores. So what are these things? Imagine researchers studying thousands, even millions of patient cases over many years. They look for patterns. Does age affect recovery from this surgery? How much does high blood pressure increase the risk of that complication? Does this set of lab results usually lead to a longer hospital stay? They take all of these complex patterns and boil them down into mathematical models, essentially these calculators. The doctor can input specific information about an individual patient, things like age, existing health conditions, lab results, the type of procedures planned, and the calculator uses that data to estimate the probability or the risk of certain things happening. Now, a huge disclaimer. These calculators are not fortune tellers. They provide probabilities based on a large group of people, not certainties for one individual. Think about it like a weather forecast. A 70% chance of rain means rain is likely, but it doesn't guarantee you'll get wet. These are tools to aid doctors and patients in understanding risk and making informed decisions together. They are part of a much bigger picture that includes doctors' experience, your specific situation, test results, and importantly, your personal values and preferences. So next time, when you're discussing a health decision with your doctor, don't be surprised if they mention a risk score or use one of these calculators. It's a sign that they are using powerful data-driven tools to help personalize your care. Pretty fascinating how data is shaping medicine, right? It's not about replacing the human touch, but enhancing it with information. What do you think about these prediction tools? Have you ever encountered one? Let me introduce some of these tools to you. We first will start with some basic tools. These are Karnofsky Performance Scale, Bartel Index for Activities of Daily Living, and Charlson Comorbidity Index. Then we will discuss POSSUM, which is Physiologic and Operative Severity Score for the study of mortality and morbidity. Let's start with Karnofsky Performance Scale. Karnofsky Performance Scale is a simple way for doctors and nurses to describe how well a person with an illness can do everyday activities. It uses score from 0 to 100. A higher score, like 90 or 100, means the person is doing pretty well and can take care of themselves and even work. Lower scores mean the person needs more help with daily tasks. Think of it as a snapshot of how the illness is affecting someone's life, like whether they can go to work, cook meals, or even just get out of bed. Doctors use this scale to understand how someone is doing, plan their treatment, and see if things are getting better or worse over time. It's a straightforward way to communicate about a person's overall well-being and ability to function. Excellent. Let's move on to Bartel's Index for Activities of Daily Living. For this, we're going to use a website called mdcalc.com. So mdcalc.com. And in the search box, you'll just type Bartel and then it shows up. And as you see, it lists a variety of activities that we do on a daily basis, such as feeding, bathing, grooming, dressing, bowel and bladder control, toilet use, transfers from bed to the chair and back, mobility on level surfaces, stairs. And then for each one, you can select different options. So let's say as one person for feeding, that person needs some help. That person is unable to do the bathing. Grooming, no issue, let's say. Dressing needs some help. Bowel control, maybe some occasional accident. Bladder control, also some occasional accident. Toilet use needs some help. Transfers from bed to the chair and back, and either select independent, or you can select needs minor help with verbal or physical help, or needs major help, 1 or 2 people doing it physically, but the person is able to sit by himself or herself, or is unable to do any of that. So let's say this person needs some major help. And then the next question would be on mobility on level surfaces. Here you can be independent. You can use some aids like cane or walker, but you should be able to walk more than 50 yards. The next option is that you need help from one person, either verbal or physical, but you're able to walk more than 50 yards. The third option is that you're wheelchair independent, including corners, but you're able to do that for more than 50 yards. And then the last option is either you're immobile, let's say bedridden, or you're able to walk less than 50 yards. So for this person, let's say the patient is able to walk with the help of one person. And then the last one is stairs. So you can be independent on going up and down the stairs, or you may need some help, either verbal, physical, or carrying aid like a chairlift, or you're unable to do that. So let's say you need some help with that too. So now you see that the total score is 50 points and this person is partially dependent. Then you can click on the next steps. It tells you that lower scores indicate increasing disability and greater need for skilled care. The total score and categorization may be used to help guide the extent of the interventions necessary in the management. However, scores within each variables are also important in guiding the focus of the treatment, such as if you have problem with just transfers or baiting or grooming. And then it provides some basic and general suggestions and recommendations. So the following are the basic measures that may be beneficial for patients, but should be considered within the context of each patient. So develop a comprehensive care plan involving a multidisciplinary team, educate and train the family members and caregivers in providing assistance, ensure the patient has access to necessary resources for activities of daily living, educate the patient on energy conservation techniques and safe ways to perform activities of daily living, refer for occupational physical therapy structured to their needs to improve and maintain function, introduce adaptive equipment to assist with daily activities such as special utensils for eating, grab bars, and transfer boards, evaluate and modify the home environment to optimize safety, such as wheelchair accessibility, hospital bed and bedroom and bathroom aids, arrange for community support services such as home meal delivery and home health aids, and conduct regular assessments to monitor progress and adjust care plans accordingly. So for patients with minimal to no needs, schedule periodic checkups to ensure continued independence, and continue to focus on health maintenance and preventive care, and encourage participation in physical and social activity. Excellent. Let's move on to Charlson Comorbidity Index. Again, we go to the mdcalc.com and in the search box, type Charlson and then it brings it up. So here you see that this assessment has a bunch of questions. One of them is about age and the rest of it is about the medical conditions that you may have. So let's start with the case. Let's say you are 75 years old. So you select 70 to 79 years category. And as you select the age, it gives you the estimated 10-year survival. So even if you have none of the illnesses that we are going to talk about, the likelihood of you surviving 10 years is 77% because you're in this age category. Now, for the sake of argument, let's say you're 82. As you see, that 77% likelihood of you surviving 10 years is going to drop to 53%. So that's how these sort of numbers do change as you enter different answers. So now let's go back to the 75-year-old. So you start with 77% likelihood of living within the next 10 years. The first illness is myocardial infarction. So if you have a heart attack, so if you select yes for that, just because of that, it drops from 77% to 53%. The next question is on heart failure, shortness of breath, leg swelling, etc. Let's say you did not have that. Peripheral vascular disease, which is defined by intermittent claudication or bypass for chronic arterial insufficiency, history of gangrene or acute arterial insufficiency, or untreated thoracic or abdominal aneurysm, which is more than 6 centimeters. Let's say you did not have that. The next illness is on cerebrovascular accident or transient ischemic attack. Let's say you had that. And as you see with that, yes, you're now at 21% likelihood of living within the next 10 years. You do not have dementia. You were a former smoker, and as a result of that, you have some chronic pulmonary disease. So you select yes. And now we are at just 2% estimated 10-year survival. So the rest, which is the connective tissue disease, peptic ulcer disease, liver disease, diabetes, hemiplegia, moderate or severe chronic kidney disease, and whether you even have had solid tumors or not, we are just focusing on that remaining 2% of estimated likelihood of living within that 10-year time frame. So it's very important for you to take these numbers into account when you're deciding whether you should receive treatment or what sort of treatment for your cancer. Let's say you're 75 years old, but you have none of these illnesses that I just mentioned. So let's select no for all of these. So you see you're at 77% likelihood of 10-year survival. Now, if you have a localized colon cancer, that is going to drop to 21%. So it's very important for you to think about these numbers when you decide whether you should have treatment for your localized or metastatic cancer or not. Obviously, the more comorbidities, the less likelihood that you're going to live within that 10 years, even without a diagnosis of cancer. So that may be helpful in your decision making. Excellent. Let's move on to the next calculator. So again, we go to MD calculator and we are going to type POSSUM, POSSUM. This is POSSUM for operative morbidity and mortality risk. So this risk calculator has two main scores. One is the physiological score and the other one is operative severity score. So let's first focus on physiological score. The first point is your age. Let's say you're 82. Then it asks you about your cardiac condition. So if you're not in heart failure, you click on no failure. If you're using some water pills or some other medications, you select this one. If you have had peripheral edema like leg swelling, or if you're on blood thinners like warfarin, you select this. And obviously this one is a lot more severe than the others. Let's say you do not have any cardiac failure, so you select no failure. The next organ that it focuses on is respiratory. So if you have no shortness of breath or dyspnea, you select no dyspnea. If you have a mild chronic obstructive pulmonary disease or you have some shortness of breath when walking, you select this one. If you have moderate chronic obstructive pulmonary disease or you have a shortness of breath that is limiting you more, you select this third option. And then obviously the fourth option is always a lot more severe. So let's say you have some mild shortness of breath. Then it asks you about your systolic blood pressure. This is the high number on when you get your blood pressure. So like usually 120 over 80, 130 over 70. It's asking you about the higher number. So let's say you usually run 140. And then it asks you about your heart rate. So let's put it at 75. Glasgow Coma scale. Again, the higher number means that you're more alert and oriented, you're conscious, and so on. This one, I would suggest that you put 15. And that's the type of patients that we are talking about. Then it asks you about your hemoglobin or your red blood cells, whether you're anemic or not. So this is, you can find it in your blood work result. So let's say you're at 12.5. Then the next question is your white blood cell count. Let's say you're 4.5. Then this is the BUN or BUN. You can find that in the routine blood work that every patient has. So let's put 25. Then you have your sodium and potassium. For sodium, let's put 140. For potassium, let's put 4. And then the next one, it asks you about your EKG. So if your EKG is normal, you select this one. If you're having a condition called atrial fibrillation or irregular heart rhythm, you select this. So to keep things simple, let's select normal for your EKG. So that is about your physiological scores. Then we move on to the operative severity score. So operative severity for the sort of surgeries that we are talking about, you are either undergoing major or major plus surgery. Let's select major. And then at times surgeons need to do more than one procedure at the same time. So that's why this is a number of procedures, 1, 2, or more than 2. Let's select 1. Estimated blood loss. Your surgeon has an idea about what would be the expectation for blood loss, especially if you're undergoing laparoscopy surgery. Blood loss is going to be fairly minimal, maybe 50 milliliters. So let's say your surgeon is expecting that there might be just 50 cc's of blood loss. The next question is on the peritoneal soiling. Again, this is something that you need your surgeon's help, but for the sake of argument, let's select none. And the next one is presence of malignancy diagnosed before or during surgery. Let's say you're undergoing colon surgery. So now you know that you have colon cancer. So it's going to be either primary only, whether there's lymph node metastases or distant metastases. Distant metastases are obviously clear from the preoperative imaging. At times, the lymph node status is unknown until the surgery is done, but you can play with this. So you can either select primary only first and then lymph node metastases and see if the numbers change significantly and whether you need to take that into consideration. Let's say you only have primary tumor. And then the mode of surgery, elective, emergency within 24 hours or emergency within 2 hours. If you're presenting to the emergency room with severe abdominal pain and the surgeon needs to operate on you right away, that risk and the stress of that surgery on your body just increases significantly. So the expectation that you presented to the emergency room and you underwent surgery and as a result is going to be a safe surgery, I think at times is unrealistic expectation. Let's say this is an elective surgery. You've been diagnosed with cancer and the surgeon has scheduled you to undergo surgery in a matter of few weeks. So that is elective surgery. So then it gives you these numbers that are very important for you to take into consideration. So the likelihood of you dying during and a little bit after the surgery, usually within 30 days, is 4.9%. And then the predicted morbidity, if you have complications or functional decline or additional assistance with your daily activities, it is around 27-28%. As you see, the risk for both mortality and morbidity for this patient that we talked about is not 0%, but it's also not 50%. The most important question for you is whether you think 5% risk of dying during and within 30 days after surgery is worth going through that surgery or not, and how much this 27-28% likelihood of functional decline, needing some assistance, maybe going to the rehab and so on, would impact your decision making. Again, you can see how they do these things change. So we talked about the mode of surgery. So this was for elective, but now let's say you have had colon cancer, but for a variety of reasons, you needed to be rushed to the emergency room because of severe abdominal pain, and they found that you have a bowel obstruction, and now they need to do surgery maybe within 24 hours, right? So now instead of doing the surgery on an elective manner, let's do it in emergency within 24 hours and see how these numbers change. So as you see now, the likelihood of you dying during and within that 30 day of surgery has increased to 7.7%, and you're more than 40% likely to have some morbidity and complications from that surgery. Let's say this is now has become a very emergent surgery. So surgery within 2 hours, and that the numbers just jump significantly. So that is why this calculator, in my opinion, is important. It's a little bit complicated. You may need some help from your doctors, surgeons, and primary care providers. Find the right answers for these questions. But overall, I think this will give you some idea about how things are.